The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you. Today we're going to do a quick podcast on a topic that's kind of near and dear to my heart. But before we do that, I just wanted to kind of touch base with everybody. You know, we've been about 2 weeks since we recorded our last podcast, continually seeing the numbers kind of skyrocket as far as total downloads on and subscribers on both Second Shift and the FlightBridgeED podcast. So I want to say thank you on behalf of FlightBridgeED and both myself, my wife, and Mike Fricest. Got some cool things happening. We have added a couple people to our platform that I'm pretty excited about. We're going to consistently be putting out blog articles. So the first one I want to introduce is Bruce Hoffman. He's a nurse paramedic, works up in the Connecticut area, and a very talented clinician, very passionate about critical care and education. So we're going to bring him on as a blog author, and he's going to be putting out blog articles on critical care, on leadership, just different dynamics of our industry. In addition, we brought on a very talented individual named Clint Klepping. He's probably going to be pretty proud that I was able to pronounce that correctly, but again, very talented. He's a very driven individual as well. Loves critical care, loves FOAMed, and he's just starting his flight career. He's been doing critical care ground, and he's a U.S. Air Force firefighter as well. So very, very excited to have both of them. They're going to be doing blog posts, like I said, as authors for the FlightBridgeED blog, and very excited to have them on board. So be checking that out. Go to the website. You'll see if you follow us on Twitter, if you follow FlightBridgeED on LinkedIn, things like that, you'll see those come out as far as a news article, and those are auto-posted to those platforms. Like I said, I just got back from AMTC. AMTC was, it was good. Got to meet a lot of great people, got to, network with many people I haven't seen in quite some time. So it was a really, really neat thing to be able to see people and just have you, the listeners, come up to me and introduce yourself. That was pretty neat, pretty humbling. So I'm back now, and we got a podcast to do. This podcast is going to be very, very quick. It should be no more than 15 minutes. I got a really nice email from a flight paramedic out of the Arizona area, Tucson, Arizona area. His name is Ryan Wyatt, and very passionate individual, has been a paramedic for a long, long time, 23 years. We have a close friend for both of us, I should say, Dave Olvera, that has kind of encouraged Ryan to write me. And I always encourage everybody, if you have a question, if you have a comment, if you have an idea, if you have any concerns, anything like that, that's why I always say those open line of communications are always open. Please email me, call me, and I will always respond and be as transparent as possible. One of his things is that, as humbling as it is, FlightBridgeED has become such a massive platform, and, it's still hard to kind of imagine the reach of FlightBridgeED. And I understand that, things that we put out as far as content goes, a lot of times becomes kind of the gold standard. I don't always want it to be that way. I want to put out information based on my clinical experience, things I'm learning, things that are trending in research and evidence-based articles, what are intensivists around the world doing, and I try to put out that information. Obviously, I'm not going to put out information. I'm not going to put out clinical standards that I don't adhere to myself or I don't practice. So I think that's one of the things that I look at before I put something out is, do I actually do what I preach? And so one of his concerns is that, obviously we have a lot of listeners that are very new to critical care, very new to the flight environment. And the things that we say, we teach, again, they kind of take that as the standard, and that's what they do. And one of his concerns was regarding RSI and the use of long-acting paralytics post-intubation. Obviously, if you've listened to our podcast, if you've started from the very beginning and gone all the way through, you know that on multiple podcasts, multiple occasions, I've talked about long-acting paralysis after intubation and kind of my stance on that. And throughout my career, I was initially taught to use vecuronium post-intubation and a very small amount of Versed, and that was about 17 or 18 years ago. And as I have progressed in my clinical practice and learning, as early as 8 years ago, I was still doing VEC on every single intubated patient, and that was just kind of the culture. But as I have kind of immersed myself in not only ventilator management, but looking at how I can become a better clinician, having that curious mind, I've realized that that's not the best approach all the time. One of his concerns is that there's definitely a time and a place for long-acting neuromuscular blockade, and I fully agree with what he's saying. I think, reading his email was very, very nice. He had some very nice things to say, and I think he articulated himself very, very well. And I think his concern is that if I come across on the podcast and I say that, clinicians that give long-acting paralysis post-intubation are lazy clinicians. And I know I've said that in the past. Obviously, I've seen that. I've witnessed that. I've actually been told by flight crews that that's why they give long-acting paralysis. They just don't want to deal with their patients, which I find, very, very horrible. And his concern is if I say that, and if people are basically taking what I say on the podcast and they're using that in their practice, that's not very objective. And so he's very, very right. Do I fully agree that we should be giving long-acting paralysis for our patients in flight? No, I don't. And I said that in my email back to him. I definitely do think that there's instances where it's warranted, and I think that we have to always look at every patient. And so I think this podcast is about kind of re-educating everybody about long-acting paralysis, when is the right indication, and then the need for pain and sedation and the new research regarding that, and why do I take the stance that I take. One of the things that I've realized, and I've based on reading and looking at different articles and talking to different doctors and MDs, is when we're flying into these small rural facilities, we've all probably shown up and we've seen these patients that have either not been given any paralysis, and they've haven't had any pain or sedation, or they've been giving a long-acting paralytic and no pain or sedation. It's slowly wearing off, and they're just absolutely uncomfortable, blood pressures through the roof. I've seen patients being held down by nurses before, and nothing being given. And so I really look at that as horrible care. When we look at the studies and when we look at the research, one of the biggest, most profound things that I've realized is that, number one, intubation in of itself, along with mechanical ventilation, just having that ET tube in the back of the throat is extremely painful. And, there has been many, many studies I've kind of talked about and quoted on both this podcast and the second shift regarding, just the comparison based on patients with second-degree burns, patients that have had their chest cracked based on, open heart surgery, and then EEG tracings, looking at those pain centers in the brain and tracing that and identifying which procedure is more painful. And so we have to remember that the pain aspect is the most important thing that we can do when we have a mechanically ventilated intubated patient. That is absolutely number one. So to me, that's kind of the first thing. The studies that I've read show that clinicians, I don't care how good you are, you could be the best paramedic, best nurse, best doctor in the world. We're human, and you have a patient that's paralyzed, and we just don't do a good enough job. We kind of forget that they're laying there. They're still, and our just basic assumption is that they're comfortable. And so they looked at these things, and I believe, and I'll have to look at it again, but I believe it was like 30 to 40 minutes in between doses of pain management and sedation. And it was more based on sedation kind of back in this study. We've also learned that sedation medications, specifically benzodiazepines, lead to disability, and they lead to disability, and we're kind of talking more the ICU setting based on delirium. And delirium is essentially a state where your patient is never allowed to kind of get into that normal sleep mode. They're always being woke up. They're being maybe sleeping during the day and not sleeping during the night. And they're kind of in that state where they can't go to sleep, but they can't keep their eyes open. I remember when I was in the ICU and I had a four-wheeler accident about 17 years ago. I remember being in that state. I remember being in a state where I couldn't fall asleep, but I couldn't really open my eyes, and I was so exhausted. Well, that really leads to disability. That leads to poor outcomes. Now, obviously, we're in a situation where we're in a flight environment. We're treating patients both acutely and chronically. Is this an initial event, or is this something that's been going on for, days or weeks? But we always have to be thinking about clinical course and what are we going to do now that's going to affect this patient 30 minutes from now, a day from now, a week from now. That's very, very important. And that's kind of the differential thing that we kind of look at from the standard paramedic, ground paramedic, to the critical care provider or the standard nurse. Now, obviously, nursing kind of looks more long-term. I think no matter what platform you look at, they're more trained to look at more long-term care plans. But paramedics specifically, we are not taught that way. So we have to always be thinking that way. Now, obviously, there are those patients that warrant neuromuscular blockade post-intubation. There was a few circumstances, or I should say a few examples that he gave traumatic brain injury. The problem I have with traumatic brain injury is, one of the things that we have to think about is what causes an increase in ICP. Obviously, they have some type of insult, whether it be epidural, subdural, subarachnoid hemorrhage, or intraventricular hemorrhage. They have some type of issue where we've got an increase in ICP. We've learned that we want to maintain that cerebral perfusion pressure for an adult at about 60, for a kid at about, for an adult about 70, for a kid about 60. So we have to make sure we have perfusion. If we have an increase in ICP and we paralyze these patients, and then just historically, based on the studies and the research, that we don't manage their pain adequately when they're in that state, pain is the number one thing that's going to increase ICP. We've looked at that. If you refer back to my ketamine podcast, where I did by myself and I did with Dr. Mike Abernathy, he talks about that a lot, is the pain is the biggest thing that increases ICP. So if we're giving long-acting paralysis and we just don't do an effective job with managing the pain just by kind of default, it's not that you're a bad clinician. It's just we just get busy. We get busy with doing other things in the aircraft, and we kind of forget. And so, that's why I've said that I've challenged myself over the last 4 years to really try to manage patients' pain. That's why I try to give a smaller dose, 50 to 150 mics of fentanyl, every 5 to 7 minutes. And then I give a small dose of benzos with every second dose of fentanyl. And so based on that, I've been really able to keep patients sedated mildly, but their pain is managed, and I haven't had to go to those long-acting paralytics. Now, obviously, there are those patients, and we look at COPD patients. COPD patients sometimes are so exasperated, they're so fatigued that those patients may need some type of rest. But I guess I argue the point of, if you are managing somebody's pain adequately with fentanyl, and you're managing their sedation with either a benzo like Versed, or you go ketamine would be a great medication in a COPD patient. Do you really need that long-acting paralysis? And I would argue no. Again, I don't want you as clinicians out there listening to just say, you know what, no matter what, I'm not going to ever use neuromuscular blockade. But what I want you to do is I want you to think critically. I want you to manage their pain liberally. I want you to be, think of it as your son, your daughter, your mom, or your dad laying there. And always think of it in that context. How would you want them to be treated? And so I guess for me, Ryan's email was very, very good. Again, very articulate. I really respect the things he had to say. He does use neuromuscular blockade on some of his patients, but he also is very good with, and I believe, he said he's very liberal with his pain management and sedation as well. Again, that's maybe the way he wants to do it, and I respect that. Just because I do it my way doesn't mean that it's absolutely set in stone. I just believe that based on least harm, dealing with the pain first, the sedation second, and managing that in the way that I've taught. And this isn't just me teaching this. This is what I teach when I teach for Air Methods. This is what I teach when I teach anybody. If I do outreach education, I teach these concepts, and so do my colleagues teach these concepts. So again, kind of have that long-acting neuromuscular blocking agent like ROC or VEC in your toolkit. Always be prepared to use it if you need it. Obviously, if it's a safety issue, pull it out and use it. But don't just prophylactically on every single patient go in and give a dose of VEC or ROC for long-acting paralysis, because I do really believe that we need to be that advocate for the patient. And I think that if you need it, you have it. But if you don't need it, don't use it. And so again, I think that we have to critically think for every patient, and not everything is set in stone. So I just want to apologize if I came across and I said, all clinicians that are giving long-acting paralysis are lazy. Obviously, I didn't mean it that way. I definitely have seen a culture. I've seen a culture based on the way I was taught. If you've been doing this a long time, you know what I'm talking about. And we see it with specific bases that have been, maybe at that base, or clinicians that have been doing this and flying for 10 or 15 years. We see it kind of in that culture based on bases that have long tenured flight crews. And it's hard to change that. So we've really, as an industry, as a company that I work for, and, based on what I teach with FlightBridgeED, I really try to push doing that. This is such a big passion that I, we kind of announced this on the Second Shift podcast, but I submitted a study to Air Methods. I'm going to do this study with a few friends of mine, colleagues, and Dr. David Stumiller out of LifeNet in New York is going to be kind of the medical director advisor. He's going to be working with us, Dave Olvera, and Charles Sweegen, and then Kelly Miller out of RCM for LifeNet of Kentucky. We're all going to look at this, and basically what we're looking at is we're looking at the use of fentanyl. We're looking at it in multiple ways. We're looking at it, number one, in an intubated, mechanically ventilated patient. If they're already hemodynamically unstable, they have a low blood pressure, are the flight crews giving fentanyl like they should, despite them having a low blood pressure? And if they do, is there any change in blood pressure? And so I'm trying to prove that there's not, that fentanyl is very stable in that situation. Then we're going to also look at the data based on, is fentanyl given with Versed? Was there any change in blood pressure? Was fentanyl given to a patient that had a normal blood pressure, and was there a change? How often was fentanyl given? So we're going to do all these kind of looking at the different data, and we're going to present this at AMTC, hopefully in 2016, October 2016. But, this is a big, big deal to me, and I think that we really, really don't do a good job industry-wide managing patients' pain. And again, pain is the number one big thing that we can look at and say, what drives up metabolic rate, drives up O2 consumption, drives up ICP, all those things. So we need to be aggressive there, and that's why I take the stance of kind of avoiding long-acting neuromuscular blockade unless I absolutely need it. So that's all I'm going to talk about based on this. I want to again thank Ryan Wyatt for sending me the email. I encourage anybody to send me email, and I love that dialogue back and forth. I respect everybody's points of view, and that's how we become better. I just want to say thanks again for all the great emails. FlightBridgeED was just rated as one of the top podcasts in the industry. There was an article written, and we were put in an article in GEMS. So I want to thank my buddy Keith Whittemeyer for doing that and writing that great article. That was pretty cool. So if you haven't reached out and emailed me or talked to me, don't ever hesitate to do that. I'd love to hear from you. And until next time, on behalf of everybody at FlightBridgeED, I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.